The case for our theme is Painful Purple Toes. The authors are John J. Ross and Brendan Everett, Jennifer Johnson, and Annie Miller, and it is being modified by Dildeep Kaur and Pire Abro, and the link is from New England Journal of Medicine. So the case that we present is initially a 57-year-old man is presented to the emergency department, and he has painful purple toes, and the preceding 3 weeks the patient has blurry vision, fleeting episodes of non-exertional sharp chest pain, fatigue, anhedonia, anorexia, subjective fever, drenching night sweats, and weight loss of about 15 pounds. And he had recently been admitted to another facility because of these symptoms, but had signed out against medical advice before a diagnostic workup was performed. The patient history is hypertension, anxiety, post-traumatic stress disorder, hiatus hernia, chronic back pain, and a history of malaria and shrapnel wounds acquired in Vietnam, benign polyps on screening colonoscopy 2 years earlier, and no history of intermittent colification or peripheral vascular disease. Medication and allergies include alprazolam, oxycodone, acetaminophen, and esomeprazole. And social habits were the following. And family history: patient reports death of father from heart disease, and physical examination included head and neck, chest, and neurological examination. The initial lab test had this outcome, and upon further tests for any bacterial infections, 3 sets of blood samples were drawn over the course of 2 hours, and additional blood tests obtained. Treatment with intravenous ceftriaxone and vancomycin and gentamicin was prescribed for presumed infective endocarditis. 3 sets of blood cultures shown had the following results. So there were no bacterial infections, everything was negative. So looking more into the case, we probed into the causes for painful purple body syndrome. Since rate of amputations are high, an aggressive management with thrombolysis or thrombectomy should be strongly considered in addition to anticoagulation therapy. Looking further into the tissue-driven factors, if you look into the causes of hypercoagulability with patients with cancer, we have tissue factor, in which tumor cells release cytokines into circulation, and factor 7 binds tissue factor and becomes activated. And looking into the treatment for painful purple toes, it was diagnosed that the patient does have hypercoagulability with cancer. Chemotherapy was suggested, which promotes thrombosis by inducing platelet activation and the release of von Willebrand factor. If you click on von Willebrand factor, you'll find out more about Medline Plus. Going back to our wiki page, we have how it could be treated, treatment. So the management and the outcome for our patient was that there was low treatment of low molecular weight heparin was initiated through injections in preparation for chemotherapy. Amputation of the first left, second and third toes was performed. Over the course of the next few weeks, there was a progressive renal failure. The patient's visual impairment worsened and he had worst episodes of psychosis. Therapy for probable pancreatic cancer was deferred because of progressive multi-organ dysfunction, which occurred despite anticoagulation therapy. When the patient's mental status cleared, he asked for a transition to a palliative care, and he died in the week following discharge. A post-mortem was not performed. So this is our case for the painful. This is our um, fictional patient, which we've named Mills Robert, and these are his particulars. And his active problems included macrodactylia of toes, blurred vision, pain, thoracic spine or chest pain, anorexia, fever of unknown origin. This patient has allergies to aspirin, and the medications that were given was heparin and ceftriaxone, and vital signs included temperature, BP, height, weight. And if you go to details here, you will know that this patient had the following reactions to aspirin: agitation with swelling. And if we go here, we'll come with the outcomes. Over the course of the next few weeks, there was a progressive renal failure. The patient's visual impairment worsened, and he had worst episodes of psychosis. And actually, the patient actually died in the week following discharge, and a post-mortem was not performed. It was admitted by a user physician and team 6, attended by team 6. The active problems were blurred vision, pain in thoracic spine, anorexia, fever of unknown origin, drenching and night sweats. Medications were heparin, which helped in injecting for patients with hypercoagulability with cancer. And these were the vitals, which had respiration, pulse, and other lab tests which were ordered, that this patient has adverse reaction to aspirin. We ordered for electrocardiology, which was the lab test. Discharge summary was that this patient actually died after discharge. White, going to the latest white. Yes, here it is. Temperature, height, weight, and BMI, which was entered by team 6. Okay, going to Oscar. Yes, this is our patient record. We have Mills Robert, and that's his date of birth, and the doctor's team 6. So we have social history as this patient being living alone, works for a post office, smoked half packet of cigarette daily, has a dog. Medical history of intracenal cocaine 1 week before admission, but reported no regular cocaine use. Reports no intravenous drug use, and ongoing concerns for the following medications. And reminders is like we sent for lab test, white blood count, white blood cells count, and platelet count, and creatinine count. And we sent for all of these lab tests. And risk factors includes that clot formation in patients with cancer increases with age, immobility and deep venous compression by tumors after surgery, like in this case of um, a cancer patient. Patient family history of diabetes. His father was a patient of diabetes, and other medicines that he took. And these were the medicines actually administered. And allergies include aspirin. Reminders. We sent for lab tests, and these were the treatments administered and prescribed. So, lessons learned would be that in the DocuWiki, it was easy to code and the whole case was laid down for us to see. It is very straightforward. If anything, like we don't understand or we don't know any terminology, we can actually click on it and we can get information about that condition very easily. And it's laid out in a very simple format with images and causes and treatments and management and outcome. But it's not very difficult to see how the case. It's good for documentation, and it was easy. And the lessons learned for Vista is that it's more like a soap outcome. You can see the subjective problem list, you can see the medications and the orders, and actually the plan taken for treating this patient. It's in a very good soap order, and you can even see lab results and vital signs and discharge summary. And it's a very powerful tool. We noticed that it is interesting how a doctor could actually go over as subjective, objective, and assessment and plan view of a patient. Um, Whereas in Oscar, we found that no vital signs could be added, and maybe it was one of the backdrops for us. But overall, we would prefer um, Vista because of the way it's being laid out, and it's too colorful, not very professional, we would say. And this being very professional, not being very showy in color. Like, we like the layout, and it was good to program in this, and it was interesting how everybody um, has their own password to log into, and putting in everybody has a role to play, where in Oscar only one person can do everything, which could be a security breach or could be a problem. So these were the lessons learned by Team 6, and we thank you all for your attention, and hope you liked our presentation.